Thank you. I'm Bhabra. I work at New Cross Hospital in Wolverhampton. In terms of disclosure, there are no financial disclosure, but I will say that my presentation consists largely of personal opinion rather than any facts. So I'll just start off by describing how our MDT works in Wolverhampton. I think we were lucky that because we were a new centre, we were able to, so we opened in 2004, and we were able to set up the MDT process from scratch and as we wanted it, rather than having sort of history between surgeons and cardiologists and trying to develop better relationships. So we spend quite a lot of time doing MDTs. We have 2 every week, so on a Wednesday lunchtime and on a Friday afternoon, and each one can last from 1 to 2 hours. We have a coordinator who organizes and runs the whole thing. The meeting is attended by any number of surgeons, whoever's free on the day, so obviously at least one, but often more than one surgeon, and interventional cardiologists. And it's an open house, so pretty much anybody can come in and present patients or take part in the discussion. So the meeting starts off with a discussion of all the inpatients that we have at that time. So all the patients who, since the previous meeting, have come in with a STEMI and had a primary PCI. We discuss their further management. We discuss all the non-STEMIs who may or may not have had their culprit vessel treated already. And we make decisions about whether they should stay in and have the surgery at the same admission or whether they should go home and be referred electively. We try to discuss as many of the elective abnormal angiograms as we can, and that's dependent on the cardiologists bringing the case to us. But we also discuss valve patients, so patients who may not have coronary disease. We welcome patients bringing back we welcome back surgeons and cardiologists bringing back patients who have had a previous discussion and have had a further investigation or an intervention for feedback or for further treatment. And so it's an open house, so pretty much anything can be discussed. So in addition to the local team, we also have cardiologists who attend from surrounding DGHs, from Walsall, Dudley and Telford. So these are the people who would come and do PCI lists in our hospital, who will then also attend the MDT. And in terms of running the meeting, I think this is a crucial part of it, is that we have a coordinator who organizes the meeting. She prepares for it, so she will try and collate names of patients who are going to be discussed, although still probably half or more of the patients are just brought on the day without any pre-warning. In the meeting itself, she runs the computers and finds the angiograms and runs them. And she keeps a record of the outcome of the discussions that have taken place, so we can refer back to them. She does this as part of her overall role, so she's the surgical coordinator who manages the waiting list and does list planning as well as the MDT, and that's a busy full-time job. In addition to our internal MDT, some of us also go out to surrounding hospitals. These are less frequent, obviously, so we go to Sandwell every fortnight, to Dudley once a month, and to one of the hospitals in Birmingham about once every month as well. And this, for me, is very informative because the MDTs in all the different places run in very different ways. The atmosphere and the personalities and how patients are discussed is very different. And of course, aside of this, we have ad hoc discussions. You often get a phone call from the cath lab or somewhere, could you come and have a look at this angiogram? What do you think we should do? And we welcome that, and we always respond, and somebody always turns up. We share the same office area with the cardiologists, and that's very useful because you can always pop in next door to your colleague's office and discuss a patient. And over and above this, we have what we call a high-risk meeting, in which, and this is once a month, usually follows our governance half day. And this is attended by the surgeons and the anaesthetists. And the surgeons bring along any patient that they think is high risk for surgery, for whom they want another opinion, for example, or if they want to make sure that the group agrees that the patient should have surgery. And the outcome might be either support and confirmation that you're doing the right thing, or it might be that the patient should not have surgery, they should have further investigation or some other treatment, or that it would be better if that patient was managed by a different surgeon with different expertise. So if the patient has mitral regurgitation, they might get transferred at that stage to a surgeon with mitral expertise. So these are all the different layers of discussions and meetings that we have. So I was asked to give a talk on who should be the MDT. Clearly, it's essential that there is at least one interventional cardiologist and at least one cardiac surgeon in the meeting. This, I guess, goes without saying. And in my opinion, a coordinator is also an essential part. In addition, I think it's highly desirable to also have a non-interventional cardiologist, because they will often bring a different view, a different approach to managing the patient. I think discussions between surgeons and interventionists are always about whether it's PCI or CABG, and it's hardly ever about medical treatment. So I think it's useful to have another opinion about whether the patient should have anything at all. And coronary revascularization is a complex thing, and you often need help with other investigations. And I think it's useful to have specialists who know more about echo, stress echo, for example, or cardiac MR scans, or perfusion scanning. And these are often not cardiologists or doctors, so we have a consultant echocardiographer who sometimes attends. Cardiac MR in some hospitals is done by radiologists, and so on. So I think it can be useful to have these people in your meetings. And then personnel, and I put a question mark there, should you have a cardiac anaesthetist in the meeting? Well, I think that's probably not very useful, because without the patient there, it's difficult for them to give an opinion. And I think we have to think about whether there should be patient representation of some type. I think at the moment it's difficult to see how that would work, but I think we do have to think in the future about whether that needs to be part of the thought process. So that's the personnel. I think other things that you need to run the meeting, you need the right information. You must have good clinical details. It shouldn't be a discussion about an angiogram, it should be a discussion about the patient. So for our inpatients, for example, we expect the junior staff from the cardiology ward to come to the meeting with the notes and to present the patients, and then we can get additional information if we need it. It's very important to have good IT and audiovisual support, so nothing more frustrating than spending ages looking for the angiogram and it doesn't run and this sort of thing. So you need a good infrastructure as far as IT is concerned. And I think it's very important that the outcome of the discussion is recorded in some way. Otherwise, it's pointless having the meeting. Somebody can present a patient, you get an opinion, and then go back and do whatever they want. I think there needs to be some way of recording what has been decided. And to this end, we have been working on an electronic way of doing this. So this is something that I've been working on with Dendrite. So we're trying to set up an electronic database, which you'll be familiar with this screen if you use Dendrite already, if you use PAT's system. So the idea is that you can find the patient from your PAS system using the usual sort of search buttons. We also have built in the sort of list where if a patient is referred to the MDT, the coordinator can add them to this list. And then you can just click on the patient, it takes you straight to their record. And then when you're discussing the patient, this screen is going to be displayed on a second projector, and it's all on one page. So we have on the left-hand side are some text boxes. The top 2/3 have some very basic background, so the patient's age, what the symptoms are, angina and dyspnea, what the presentation is, non-STEMI or chronic stable angina, for example, any major valve problem and any comorbidity. And then on the right-hand side is a display of a very simple display of the coronary artery tree. And the idea is that patients who are going to be discussed, this can all be entered before the meeting, so the data is there already for you to see. And so this patient, for example, has stable angina, and this is web-based, so a simple mouse button click. We've got two layers of information here. The first layer is to define what we think the coronary abnormality is. So for this patient, we think this mid-LAD significant stenosis. And the second layer is a decision about what treatment. Yeah. So this patient, we think, should have a PCI to the LAD. And that's recorded in the bottom third of the information here. So that can then be exported as a PDF and either emailed or printed. So that's a summary of the patient's background and the decision making. So slightly more complex patient with diabetes, with 3-vessel disease. So the first layer of information is to identify that there are significant stenosis in the right coronary and circumflex arteries and an occlusion of the proximal LAD. And the second layer is to say that the MDT thinks that these 3 vessels need to be grafted. Okay, so it's the disease and what we think the treatment should be. And again, you're going to export that as a summary. So this patient, we think, should have a PCI to the right coronary artery and a pressure wire to the LAD. So one of the functionality is that we also have an attendance box. So the coordinator can click the names of the consultants who walk in and out of the meeting so that we can capture who was there in the room at the time the discussion took place. So that's a work in progress. So we talked about personnel, and we talked about IT and so on. One of the things I think is some human ingredients, and this is much more difficult. I think that it's very well having a surgeon and a cardiologist in the room, but they need to be well matched. I think if you have a senior professor of cardiology and a locum surgeon who's only been in post for 6 months, it's a very unbalanced discussion. I think you do need to have the right people in the room. And you can often tell when more people join in to the MDT how the atmosphere changes and the balance of decisions moves subtly from one way or the other. And I find that very much when I visit other hospitals as well, that initially when we went to Birmingham, for example, to the hospital that I won't name, there was quite a hostile atmosphere, and they treated you with great suspicion. But over time, and it took about 6 months, they learned to trust you and to respect your opinion, and you can then get a much better rapport. I've said that you need, the surgeons need to have knowledge of the evidence that's out there for supporting what they do. Otherwise, you can't stand up and argue your case. It needs to be an open forum. Anybody should be able to attend and express their views, no matter how junior or how senior they are. And you need to be able to respect each other's professional opinions. So just to summarize, I think that every center is different, and MDTs will work differently in different centers. Some will have bad history between surgeons and cardiologists, and it's very hard to say how you should get around that. I'll also make the comment that in my opinion, or in my experience, cardiologists disagree more with each other than they do with surgeons. So we get much more discussion about how a patient having PCI should be managed rather than whether they should have PCI or surgery. And just the last statement there is, I think the important ingredient really is that we do need to have professional respect for each other. Thank you.